the first piece that we had it was really based on clinical practice from the UK, and it's still incredibly powerful today, was actually how it was being used by doctors who've been using it. This paper, I don't know how many years old it is now, but what we found was there was three things. One, people were using it to make a go, no go decision on when to use inhaled steroids in people with vague symptoms. Two is a bit of an adherence support. So when seeing patients who are poorly controlled with their asthma, and people were not sure when patients said they were adhering, and yet their FeNO was sky high, people would go, no, you can't really be taking your inhaled steroids, and actually showed an increase in adherence after that. So I think those were the biggies for me of the gain from that original real life research. Now we've done rather more interesting things since then, and one of those was a retrospective study looking at people's current asthma control and their prior exacerbations versus their FeNO and blood eosinophil count. And what was really interesting there is that they were both independent predictors of the risk of exacerbations of asthma. So clearly very helpful in determining risk. Then I think the piece that I found the most interesting for me was supported by an academic grant from Circassia, where we randomized patients to inhaled steroids or placebo who had what we called non-specific respiratory symptoms. These are people with cough, wheeze, shortness of breath, but without objective reversibility supporting a diagnosis of asthma. So these are the patients where you're saying, do I give them a trial of inhaled steroids, don't I? And what we saw was that there were two independent predictors again of response, FeNO, strongest predictor, but also blood eosinophil counts, independent, and both predicting symptomatic response to inhaled steroids over placebo at 1 month. So clearly a very good signal on predicting who would symptomatically do better. So I think that was very powerful for me in saying, you got this patient, you really don't know what's going on with them. Well, this is a great way to work out whether you need to give them inhaled steroids or not. So those are the biggies for me. There are other pieces of work that are we had a pediatric study which sadly has not been so clear cut. We did try and do it was government funded in the UK, where we randomized people to personalized management of their asthma according to their FeNO. The trouble was these were all patients in severe asthma services for kids. And they were pretty much at the top of the dose response curve for inhaled steroids. So there was nothing really to be gained, I think, from increasing their therapy further. So both groups got big improvements, and difficult to ascertain where the FeNO assists in that particular position. Certainly the adult studies would suggest it's also very helpful in predicting who's going to respond to higher doses of inhaled steroids. And then I guess the final pieces of evidence are those that are coming through from our international severe asthma registry, where we've got an algorithm that looked at eosinophilic asthma. And by looking at both, we used eosinophil counts and FeNO as part of that algorithm. And what the big message for me was that only about 5% of people with severe asthma were non-eosinophilic, if you include FeNO within that definition. So the vast majority of people with severe asthma have what we might call T2 disease. So disease that is going to respond to T2 therapies. So that's both inhaled steroids, but also our biologic therapies too. So I think that's, for me, some of the key real-life studies. Clearly, there is a population of people within COPD who have T2 disease. I mean, even on average, the blood eosinophil counts of people with COPD are higher than they are in a non-COPD population. So they have inflammatory disease going on. There's not the big studies of FeNO. My hunch is that it would predict response to inhaled steroids in COPD, and it may also predict the response to some of the biologics. And I know there are emerging studies coming along that will also look at that. Cystic fibrosis is a harder one. There will be some of those that maybe have an asthma element. I mean, what we're really looking for, of course, is treatable traits. And I think one of the pivotal things that's been happening over the last 10 years in asthma originally, but certainly in the COPD world as well, is to say, what is it we can treat in this patient? You know, sure, you can give bronchodilators to those with bronchoconstriction, but what about who's going to get the benefit from the T2 therapies, inhaled steroids, and potentially the biologics? So I think there it's going to be potentially very useful. We just don't have the slam dunk evidence that we'd like to have. Real world data is always interesting. So I mean, our institute is called the Observational and Pragmatic Research Institute. We've put those two words in very deliberately. So there's the observational data sets, and then there's the pragmatic trials, which is sort of like more real life clinical trials. So the observational data is great for some of the predictive work, which is why we were able to look at FeNO and eosinophil counts and show that they're independent predictors of exacerbations, for instance. Where it gets a little bit harder is where you do a measurement and you know doctors' behavior changes. So there's a series of studies that are looking at the use of FeNO and also eosinophil counts in real life settings where doctors are made aware of those findings and patients are made aware. And the trouble is, as soon as you tell people that they've got a high FeNO count and then that could be related to them not taking their medicine, suddenly you've changed the whole game. So very hard then to look for predictive results. So you've got to try and generate real life data when, if you like, I say you've got to have clinical equipoise. Because if you can't, otherwise it's very difficult. And particularly when you then start to look at drug studies in real life data sets, because what you need is the data, and different doctors get the same data, they get the same type of patients, but they do different things. So effectively, you've got a randomized trial in real life, if you like, with a random element going on. If that doesn't exist, and for instance, you only do a test at a certain point in the pathway, it's not very helpful. And I guess for me, one of the big challenges is that to date, our international guidelines or strategies have left the biomarker assessment at the severe asthma end or difficult to treat asthma end, when it's all about helping to select the right treatment. My philosophy would be, and I may be in contention with others, is that we really need to understand what it does at the beginning of the asthma journey, so that we're then saying, hang on, this is a high risk patient. This is a patient who needs to have a better intervention. Or this is a patient who doesn't really have much evidence of T2 disease. Are we really sure they've got asthma? So I think and the reason I'm talking about that is the body of evidence that we have on FeNO is pretty restricted in observational studies in real life in milder asthma, whereas we're starting to build the evidence in severe asthma. So that's one of the challenges there. I think then when we come to the RCTs of does it generate and improve, the outcome, predict outcomes, I mean, I've been in discussions with the GINA guideline group about our trial about, using FeNO to predict an inhaled steroid response. And in our discussion already, I made the point that it predicts symptomatic benefit at 1 month. What it doesn't tell us is, does that also translate into reduced exacerbations at a year? Also, does it tell us if it's negative that patient doesn't need inhaled steroids, particularly if it's negative and their eosinophil count is negative? So those are some of the bits of, and funding those big studies is obviously a big challenge. Mild asthma studies are difficult. So some challenges there, but I also think we've also learned a lot already from what we've got in real life. So we've seen things like the novel START trial, which was using budesonide formoterol as needed versus more usual care, and a very nice trial. And the challenge we have with these is really characterizing and getting a breadth of enough patients to really assess whether what the value of the biomarkers are. So you do need big numbers to really draw these things out. You do need to have patients really well characterized, and you have to follow them up for long enough. So I think there's always the challenge of getting enough, if you like, big data in those real life studies that enables you to really do those additional analyses. And I guess that's where also more real life observational data comes in. And I got quite excited for a while last year because there's been quite a big group in the UK encouraging the use of FeNO in primary care. Then, of course, obviously COVID's come along and messed that all up. Because I was hoping that with a lot of FeNO data coded into EMR, electronic medical records, so-called EMRs, that would enable us to build up some very big data sets. We are starting to see that data get in there, but really we do need that type of big data to really answer some of those bigger questions. So better characterization, bigger numbers in the pragmatic trials, and then for the observational data to really generate high quality background data. I mean, one of the great things certainly in the UK and to some extent in the US has been the advent of increasingly valuable electronic medical records. I mean, our database, we have 17 million patients in the OPCRD, and it's really nice for many of those patients. We've got a median follow-up of 27 years of data, so we know about people over a very long period. So the more information you can get in there, the better. And doctors in the UK have certainly been encouraged, at least in the past, to record more standardized data in asthma. The shame is FeNO's not been part of that, but if it was, it would be absolutely phenomenal. So hopefully, but we do need more information in those settings, if you like. Which is actually doctors who use it can never do without it. And that's quite hard to quantify why that is. And that's what we tried to do, really. And this was primary care physicians. I mean, they were all with a respiratory interest. But what came through, I think, from that was that they worked out where it was really useful. And as I say, they found it very useful in that, should we be treating this with inhaled steroids, shouldn't we? Maybe we should be increasing the dose of ICS, or is it just poor adherence? So very, very useful, I think, in those places. From a research perspective, I mean, I think we've talked about it a little bit already, but I think it would be incredibly valuable to understand. We know that eosinophils are incredibly helpful in predicting the beneficial response to inhaled steroids in COPD. And I'm sure FeNO would be similarly useful. People talk about smoking impacting on it, but it's only a relatively small amount. So that's where I would be very excited. And when I was doing I used to do a special interest clinic, and we had a lot of COPD patients, and we did have FeNO available, and you did get some very interesting surprises with people with very high FeNOs. And and you didn't know I mean, there was maybe a few hints. They had their their COPD start before the age of 40. So there were a few things there, but not that many. But that also alludes to the point that we've seen from the novelty trial, data published now. It's not trial, observational study, but 13,000 patients with asthma, COPD, unsure diagnosis. That reversibility was not predictive of who would have an asthma or COPD label. So, we spend a lot of time doing tests that don't really make the diagnosis. And I think FeNO is incredibly valuable at getting into that whole treatable trait, as is a blood eosinophil count. I can't do without them for research. And And I don't think you can do without them in clinical practice once you've used them. I mean, patients love it, I have to say. People like to have a number. And so I think it's very nice to be able to look at that and also look at how it changes in response to therapy. You know, it's very nice to be able to show patients that your FeNO was 50, we started you on inhalers, and look, it's down to 20. Yes, your symptoms are better too. This shows the value. You've calmed down the inflammation in your lungs. You know, we've got to carry on with this type of treatment. You know, that's a really cool way to start. So those are very helpful ones. I think the other place where where it's very useful when people are new is that patient, I really don't know whether I should be going up to a medium or a high dose ICS LABA, or should I just be keeping on a low dose one? That sort of space there. And then I also think it's quite helpful at that point when for primary care they're thinking about referral. So that's where you've got the value of the FeNO or the eosinophil count. If they're either one of those are up, you know, you've got your patient who might well do very well with a biologic, who's uncontrolled with their therapy. And from a specialist perspective, you know, I think I personally don't know how anyone can manage without it in severe asthma today. I'm delighted to see, I mean, we had a lot of gaps in that sort of data when we started ISAR, International Severe Asthma Registry, 5 years ago. We're increasingly seeing it as being a very normal test, at least as part of the first assessment for patients with severe asthma. Ideally, we have the longitudinal data, because I do think it's also, again, very nice, particularly if you start people on drugs that may lower it. And interestingly, we do see it drop, not just with the ones that you would expect to, like an anti-IL-4/13 drug. We also see it dropping with anti-IL-5s too, which is quite interesting. So hopefully those are some useful thoughts for people.